Welcome to the Hematology section of the Step 3 USMLE course. I'm Conrad Fisher, and we're going to engage with the details of hematology. Now, unlike other specialties, hematology has relatively few changes over the years. If you think about what new hematologic diseases there are, you realize there are very few, if any, new hematologic diseases. It's not like infectious diseases. 25 years ago, there was no Legionnaire's disease. 20 years ago, there was no HIV. 15 years ago, there was no Ehrlichia. 10 years ago, there was no hantavirus or Ebola. Hematology is relatively fixed and permanent. If you stop for a few hours today with me, invest your time in hematology, you'll never have to learn this again as long as you live. Because it's not going to be different next year. Think about it. Think about diseases like B12 deficiency. The latest therapy for B12 deficiency is... It's still B12? Damn it, if it wasn't just B12 last year. And it's still B12. The treatment for iron deficiency is iron? Well, let's wrap up and all go to dinner, don't you think? What do we need class for? The treatment for folic acid deficiency is folate. Oh, you're such a good and responsive group. That's the way I like it, okay? So therefore, if you think about it, the number of hematologic diseases has not changed. The therapies, in large part, have not changed. So therefore, if you become a hematologist and you realize that you just spent several years in a fellowship, and at the end of that fellowship, you get to the end of it and you realize there are no new diseases and virtually no therapies. But you need to make yourself useful. There's only one thing you can do to make yourself useful. That is to make it as complex as possible so that no one else can understand you. And that's what we're at here. Deciphering hematology. So we're going to look at this. Or we're going to say, here is anemia. I'm without my emia. Emia. Where's my emia? I had some emia just the other day. Now I'm anemic. I'm without my emia. Now all causes of anemia, no matter what the source, all have the same symptoms based on the severity, but not the etiology. The symptoms are based on the severity, but not the etiology. If you think about it, folic acid deficiency with a hematocrit of 20 has the same symptoms as iron deficiency with a hematocrit of 20. Has the same symptoms as thalassemia with a hematocrit of 20. It's not the etiology, it's based on the severity, the symptoms of all anemias. So here we have this old-fashioned thing called the hematocrit. And when your hematocrit is greater than 30 to 35, the most common presentation, the most common complaint for an anemia with a hematocrit of 30 to 35, the most common presentation is people complain of nothing. They go, I'm anemic? Really? I didn't know that. I'm anemic? I didn't know that. Really? I've got a crit of 34? I didn't know that. People don't feel a hematocrit like that. People don't feel a hematocrit of 36. People don't feel a hematocrit of 34 most of the time. It's when the hematocrit goes down below there and you start having hematocrits at 25 to 30 that the most common presentation and most common complaint is fatigue. See, you don't have to have the right answer. Just have any answer and I will bring you a question and make you right. I want you to be happy. Fatigue, malaise, I'm tired, I'm so tired, oh my God, I'm so tired. Now when a hematocrit starts to go lower, down below 25, depending on who you are, you start to develop some shortness of breath, some dyspnea on exertion or at rest, on exertion or at rest. On exertion, mostly on exertion. Here I am at rest. I've got enough oxygen. I'm delivering enough. I'm okay. Now I need to climb some stairs. And I go walking up my stairs, and all of a sudden I need to deliver more. And all of a sudden, I can't deliver enough because I don't have enough oxygen carrying capacity. I don't have enough red cells to deliver, and I'm walking, and I can't deliver. And I've got a muscle over here, and it wants some oxygen. And it can't deliver any oxygen to that muscle. What am I going to do? I get short of breath, but I'm okay at rest. They didn't do this in your medical school? No. That's why you needed to be here. All right. So you're at rest and you're okay. But as soon as you start exercising, you need more oxygen to be delivered, but you don't have enough red cells to deliver the oxygen, so you get very, very short of breath when you're walking around, when you're exerting yourself. Dyspnea on exertion. And then as the hematocrit goes down below there, you start to get confused and lightheaded. Confused, lightheaded. Sometimes if it happens, you even develop syncope if it happens more rapidly. And I know the more rigid and too early potty trained amongst you are saying, wait a second, which one is with which one? Which one is it dyspnea with? Is it with that one or that one? I can't see it. It looks like it's overlapping. Which one? It looks like it's overlapping. And the answer is, yes, that's right. It's overlapping. It's overlapping because it depends who you are. Healthy young guy like him? Any congenital heart defects? Do you see me? Am I in a bitemporal hemianopsia? No, you didn't take your meds and you think I'm a part of a delusional structure. In your case, I am. But okay. So no cardiac defects. How old are you? Let's make you immortal here. Turn around. How old are you? Hi. How old are you? That's not supposed to be a hard question. So you're an introvert. I can accept that. But the issue is, relatively healthy 27-year-old guy? Yeah. Oh, good. Oh, I know what it is. You're so used to multiple choice. You can only get it when I get your age, and I gave 3 or 4 or 5 separate ages. You choose yours. That's good. Healthy 27-year-old guy won't feel a hematocrit of 30. Might get short of breath and confused at a hematocrit of 20. Probably won't die until his hematocrit is 10. 77-year-old guy, history of heart disease, might get symptomatic at a hematocrit of 29. Might be dead at a hematocrit of 22 or 24. Depends who you are. Depends who you are. I wouldn't transfuse you until your hematocrit went down to 20. Why bother? Reticulocytes. Retic. You'll make your own. Depends who you are. You'll have no symptoms. Older guy with heart disease might be dead at a hematocrit of 27. How do you die of anemia? Huh? Heart failure is the answer that I'm looking for, because it represents an idea of what you come for. You think you come for the right answers, and that's true. But if you're looking at multiple choice questions, you realize that if you look at all A, B, C, D, E, you really know right away that 2 or 3 of them are wrong. You go, A, B, C, D, E. Well, I don't think D and E are right. I know D and E are not right. C, I don't think that's it. But is it A or is it B? I'm not sure. So congestive failure is the most common wrong answer. So if we not can see what the most common wrong answer is, it pushes us into what the most common right answer is. How long does it take to develop congestive heart failure from anemia? How long does it take to do that? 20 minutes? 2 days? Years. Takes years. So you got to have a guy with a hematocrit of 21 and leave him there like this. Doctor, who's this patient you have here? Oh, this patient, that's our high-output congestive heart failure patient. He has a hematocrit of 21. His body needs more oxygen carrying capacity, so it increases cardiac output in order to compensate. that is so interesting. Tell me, have you ever thought of transfusing him? Oh, well, we did think of transfusing him several years ago, but then again, who would the medical students have to examine? We leave him here year after year with a hematocrit of 21, allowing him to develop high-output cardiac failure. High-output failure is not the most common cause of death. The only way to get high-output cardiac failure is to be left untreated for a very long time, and it doesn't happen here. There's two ways to basically die of most things. Neurologic, insufficient perfusion here, and cardiac, insufficient oxygen carrying capacity here. It's got to be either here or here. Most common cause of death, CNS or cardiac? You're doing this. You're like bidding at an auction. I can't wait till we get to the urology section. What will you do? The answer is heart is how you die. Think of it this way. I have two answers. We either have the scientific answer or the poetic answer. How do you die of anemia? Here's the scientific answer. It is possible for you to meet brain death criteria and still have a beating heart. The heart, because of its intrinsic automaticity, is capable of beating on its own even with the absence of CNS input. Therefore, a patient can be certified as brain dead and still have a beating heart. You can have negative pupillary reflexes, negative oculocephalics. Pour cold water or chicken soup into their ears, no nystagmus. Negative EEG, flatline EEG. And still be alive, can't you? You can be brain dead. That's right. That's what I'm looking for. I prefer amen. I love it when you get all squeaky like that. Who's that there? Okay. So, you can be brain dead. You could have negative pupillary light reflexes. Negative oculocephalics, negative cold calorics, no nystagmus, flatline electroencephalogram, and still be alive. Brain dead, but your heart's still beating. So you got to die from here. That's when you die, when this stops. The other way is thinking of it like this. The poetic way of thinking it is, which do you need more, your heart or your head? Would you rather be very, very smart but very cold-hearted? Or really sweet and warm and loving and a little stupid? I think it's better to be really nice and sweet and warm and loving, and a little stupid is a lot better. So that proves that you can live without a lot of your brain, but you cannot live without the heart. Okay? From the Little Prince, right? I will tell you a secret, said the fox to the little prince. It is a very simple secret. That which is essential can only be seen with the heart, said the fox to the little prince. Now, ultimately, you die of an MI. GI bleeders die of MI. People who have acute blood loss may have syncope, but you die of an MI. Because if you are a myocyte in the left ventricle, if you live inside the left ventricle, you can't distinguish between stenosis in the coronary artery versus carbon monoxide poisoning versus anemia. You can't distinguish between those things. Anemia, carbon monoxide poisoning, and a stenosis in the coronary artery all look the same to you. They all mean that you are definitely not getting enough. Okay. Now, that is irrespective of the etiology of the anemia. Now, when you're trying to determine the etiology of the anemia, the first thing to look at is what? Once you know their hematocrit is low, what would you look at first to determine the etiology of the anemia? MCV, Nosmia. MCV. High MCV, low MCV, normal MCV. High MCV anemias basically mean B12 and folate deficiency. B12 and folate. B12 and folate deficiency. High MCV anemias mean basically B12 and folate deficiency. B12, folate, and certain forms of drugs. B12, folate, and certain forms of drugs. What is the most common drug to cause macrocytic anemia? Alcohol is not a drug? Huh? Sideroblastic, but that's not what I said. I said, what's the most common what's the most common drug to be causing a macrocytic anemia? I love when you do that. Don't give to it. Phenytoin. No, alcohol. He was right the first time. There are many more people who are using Budweiser than there are using phenytoin. You can go to any supermarket and get a 6-pack of Budweiser. You can't get a 6-pack of phenytoin. Methotrexate. I'll have a methotrexate and tonic tonight. Phenytoin, methotrexate, 6-mercaptopurine. Oh, I have the beef with the 6-mercaptopurine sauce. No. The most common drug is not methotrexate, phenytoin, or 6-mercaptopurine. It is alcohol. Low MCV anemias, of course, is iron, sideroblastic, thalassemia, and chronic disease can be either normocytic or micro. Very good. I love fill in the blank. Chronic disease can be either normocytic or microcytic. Could be either one of these. It can be either one. But it fits in better with microcytics because microcytics are all production problems. Now, normocytic anemia, normal MCV, means basically two groups of problems. What are the two groups of problems? Hemolysis and bleeding and some form of blood loss. Hemolysis and bleeding. Hemolysis and some form of bleeding. Hemolysis and bleeding. Hemolysis and bleeding. Hemolysis and bleeding. The other thing I'd like to point out is that when they give you any case history that says acute anemia, anything that says acute anemia has to be normocytic, either blood loss or hemolysis. Just by knowing it's acute. Look here at the micros and the macros, the micros and the macros. These are production problems. Production problems can't be acute. Production problems can't be acute. B12 and folate. How long does it take you to become anemic from B12 deficiency? A couple of years, that's not so acute. Drug effect on the marrow takes weeks at a minimum. Weeks and weeks. Thalassemia is a lifelong problem. Even iron deficiency takes weeks to months to develop. How often is the anemia of chronic disease acute? Some of you get the joke, and some of you are thinking. I don't think so. No, it's not acute. So when they give you an acute problem has to be hemolysis or bleeding. Has to be hemolysis or bleeding. Either one of these things. Let us go to look at the case. But this is how we're going to address all forms of anemia. The symptoms will be based on the severity and not the etiology. They'll be based on the severity and not the etiology. We have a Greek man at a Greek restaurant and an unreadable case that's making me crazy. Okay. He comes with acute ding 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 ding. One word. Got to be either hemolysis or blood loss. One word. This is an anemia. It says acute. It's acute. It says, it's got to be hemolysis or blood loss. Got to be hemolysis or blood loss because it says acute. But let's keep going. He's a Greek man going to a Greek restaurant. He says, no fever, no chills. And it says, look at this. I'm jaundiced. I'm tachycardic. He goes, I'm a Greek man going to a Greek restaurant. He has Primaquine as an appetizer. fava beans as a main course and dapsone for dessert. So we have a guy here who's got acute onset of fatigue, back pain, headache. He's jaundiced. How do I know that this is not hepatitis? How do you know this isn't acute hepatitis? It says acute, and I've heard that acute hepatitis has the word acute in it too. How do I know this is not acute hepatitis? Huh? The incubation period. Well, the incubation period is asymptomatic. No, he couldn't have acute hepatitis from what he ate for lunch. That's true. But you don't feel the incubation period. How do you know this is not hepatitis? Fever? No, hepatitis can give you a fever. He's got a fever. Several hours. And as acute hepatitis is, it's not acute over several hours, is it? I was walking down the street, minding my own business, and all of a sudden, I got acute hepatitis. All of a sudden, like this, just walking down the street, doing nothing. I got acute hepatitis. No, it doesn't happen that fast. Not that fast. Not that fast. It just doesn't happen that fast. How do you know that this is not blood loss then, if I said that the two things that give you acute problems are blood loss and hemolysis? If it's blood loss and hemolysis, how do I know that it's not blood loss then? Huh? Blood would be coming out from somewhere. Blood would be coming out from somewhere. Blood might be coming out from somewhere, that's true. The other thing is, give me another reason. Well, I don't know, maybe it's all in his belly. How do you know it's not a retroperitoneal bleed? Might be inside him somewhere. Maybe it's into the uterus. Yeah. No, it's because you don't get jaundice with blood loss. His chief complaint is jaundice and dark urine? And blood loss doesn't give you jaundice and dark urine? Oh, I bet you knew that, though. You knew that, didn't you? Of course you knew it. He knew that. See, one part of him said, I know that jaundice and dark urine and light stools does not go with blood loss. Another part of him said, well, it's acute cause of anemia. It could be blood loss. And you knew it. It's just not crossing your corpus cavernosum. Callosum? Callosum? What's the difference? Yeah. So we have an acute problem. Blood loss or hemolysis. How do I know it's not blood loss? Because blood loss doesn't make you jaundice. Doesn't give you dark urine. Doesn't do that. Blood should be coming out of somewhere, like hematemesis, hemoptysis, or melena. That's true, but you can put quite a lot of blood into your guts and still not have actual external blood loss. It could be. Now, here's the basic issue of why we're doing this. We're preparing for several basic questions. Number one, this history, this physical, and the question says, which of the following is the most likely diagnosis? We're preparing for this history, this physical, and it says, which of the following is the most likely diagnosis? But maybe they don't ask you that. Then they take the same history and they say, this history, this physical, which of the following is the best initial diagnostic test? But maybe they don't ask you that. Because we're in the hematology section, and in the hematology section, the best initial diagnostic test is always a CBC. Yeah, check me in cardiology, because it's an EKG and a catheterization. Today's answer, the magic word is CBC and a bone marrow. CBC and a bone marrow for all the hematology section. So the best initial test is always going to be a CBC. But maybe they don't ask you that. And they say, what's the most accurate diagnostic test? And maybe they don't ask you that either. You could take this history and physical and say, which of the following is the most likely diagnosis? What is the best initial diagnostic test? What is the most accurate diagnostic test? And then they don't do that for any of them. And they don't do that for any of them, and instead they say, this history, this physical, what's the best initial therapy? Now, we're going to look at every one of these cases. I want to practice every one of those questions. What? No. It's a principle. Okay, it's a principle. We'll get to treatment on this. But it's a principle about looking at each one of the diseases. Each one of the diseases You walk into test day saying, for this history and this physical, for this disease, how will I recognize the answer to the question, which of the following is the most likely diagnosis? Like in this case, I said, this can't be any of the micros or the macros. It can't be any of these or any of these, because none of these are acute. And it can't be blood loss, because blood loss doesn't make you jaundiced. So automatically I recognize this as hemolysis just from the history and physical. I haven't even done the CBC yet. But maybe they don't ask you that, and they say the best initial test, or the most accurate test. Maybe they don't ask you any of that, and they say, what's the best initial therapy? The idea is to look at every single disease walking in and say, how do I know to answer each of those questions? What are the answers to each of those questions for each of the cases? Now let's have some rules. All relationships have little rules. Okay? You might say honesty, and I say, not yet. Let's skip the honesty and go straight for the other. Okay? No, the rule in the relationship is this. You can do pretty much whatever you want. You can come late, leave early, whatever you want. You don't even have to call me doctor, call me Conrad, call me sweetheart, call me whatever you want to call me. You can do whatever you want, because it's a different type of relationship. There's only one thing I'm going to insist on. And that is, you notice how I have that case covered up there? You notice how I have it covered up? I have it covered up on purpose. I have it covered up so that we can look at the history and physical and say, what's the most likely diagnosis, without the answer in front of you? I have the history and physical there so I can say, what's the best initial diagnostic tests? And you have it covered up. So therefore, the only thing I'm going to insist on, and you should do that out there too in videotape land, show a little discipline, just like me. Show a little personal discipline, a little restraint, why don't you? And cover up. Cover up. Don't show it all just at once. Make him work for it, okay? If you reveal it too early, it won't be as valuable. So cover it up. Cover it up, okay? Don't worry, we'll get a brass pole put in here soon. All right? Why do you know what that means? I can understand why he does, but I can't understand why you do. All right. So, you've got to cover up. Hello! Do we have a learning disability? Cover up! Allow me to help you. Ready? I just wanted to hear you make that noise. You've got to do that. You could do whatever you want otherwise, but this is an exercise to make you learn. You don't do practice questions with the right answer circled, do you? Oh, half of you are nodding, yes I do. Yes I do. I circle the right answers. It makes it much easier. Well, that's the point. That's the problem. How do you know what the right answer is? Now, in this case, we have to prepare for two different things simultaneously. We have to prepare for both single best answers and for CCS. Now, 80% of the questions, I was having this discussion with an important person yesterday, 80% of the questions are single best answers. So we have to prepare for the fact that 80% of the questions are going to be history, physical, maybe some labs, maybe not some labs, and 80% of them are going to be single best answers. Which of the following is the most likely diagnosis? What's the best initial diagnostic test? What's the most accurate diagnostic test? What's the best initial therapy? And only 20% are going to be clinical case simulations. Now, although only 20% of the questions are clinical case simulations, it's 80% of the anxiety. 20% of the cases with 80% of the fear. We have to prepare for both of these simultaneously. Are we covered up yet? It's the only time you're ever going to hear me say that. Chief complaint. History of present illness. String of vital signs. And from this point, it goes to any one of four things. Let's do some physical examination. Let's order some labs or some treatments. Orders can be either tests or treatments, either one. Let's move the clock forward as we adjust to time. Or let's change the location. Now, from this patient here, we have to prepare for both of these. I want to write some orders. The orders could be tests or treatments. I can move the clock forward. I could change the location. I can do anything I want. I can do anything I want. And that's what's so anxiety-provoking about CCS. What's so anxiety-provoking about CCS is the right answer is no longer in front of you. Look what happened to you about your age. You couldn't figure it out until I gave you multiple choice, right? Sex, male or female? It said that wouldn't be on the exam, you know. Because there's no true-false questions on the exam. You have to prepare for both of these. How much physical exam will I order based on each history of present illness? What orders will I write? Will I write tests first or treatments first or both? Here, in single best answers, I can only do one thing. One single thing at a time. Here, I can order 100 tests and treatments all at the same time. And that's why you get anxious. It's like, oh my God, how much do I order? I don't know. I can move the clock forward. And once you move it forward, it doesn't move back. Or I change the location. And it doesn't tell me which one. I could go to any of these. I can go to any of these. I can go to any of those. And it doesn't tell me which one. So, on to this case here. This guy with acute symptoms, we know has to either be blood loss or hemolysis. Because there's back pain, dark urine, we know that this has got to be hemolysis. So all the types of hemolysis that there can be autoimmune, there can be sickle cell disease, there can be glucose 6-phosphate dehydrogenase deficiency, there can be hereditary spherocytosis. What do every single one of those have in common? Every single one of those have certain things in common. What do they all have in common? Hemolysis. Yes, that's very good. That's why it says hemolysis. That's right. They all have hemolysis. Please cover your left eye and read the lowest line. I know, but what do they all have in common diagnostically? Huh? Morphology. You mean they're all normocytic? Yeah, I accept that, Don't tell me anything that I've already taught in front of you on the board. Yes, anemic. Yes, anemic. I'm having an existential crisis. Yes, it's anemia, normocytic, and hemolysis. But they're not intravascular. Jaundice. They all have a high bilirubin. They all have a high bilirubin. They all have a high reticulocyte count. They all have a low haptoglobin. They all have a high bilirubin, a high reticulocyte count, a decreased haptoglobin, and they all have... you're stuck now because it's not written on the board in front of you for you to read out. It's difficult. Huh? They all have a... I'm sorry too, but I have much more to be sorry about than you. What's this? Some sort of autoeroticism, right? Okay. Oh, good, you can read. Now there you go. There he goes. LDH. That's very good. That's what you do. That's what you do to finish it when you're on rounds with your attendings. He goes, they have an increase, you go, and he goes, LDH, H. You finish the sentence. You go, LDH. LDH. I was just about to say that. LDH. That's plan A. Plan B is, oh, you're so smart. Okay. Whichever one of those you can get away with. I'd go with the LDH thing if I were you. Okay. So that's what they all have in common. All of these have this in common. They all have this in common. So the point is, what one thing is going to be unique about autoimmune hemolysis? What one thing will be unique about it? Coombs. It'll be the only one that is Coombs positive. It'll be the only one that is Coombs positive. Okay? It'll be the only one that is Coombs positive. The only one. Okay? Now, what's going to be unique about G6PD? You see, we already do this thing here. These initial tests, and we find just as we said, that we know that we have anemia. We know that we have anemia because that's what it says in the history. Okay? We know that we have a elevated bilirubin. That's all indirect. We know we have an elevated indirect bilirubin. And normal transaminases. We said that there couldn't be hepatitis anyway because it was too acute for this to be hepatitis. It was too acute for this to be hepatitis. Okay? Now, when you go into your bathroom, when you go into your basement, when you go into your garage, and you see oxidized iron, and you're in your bathroom, your basement, and your garage, what do you call that oxidized iron in your bathroom, your basement, or your garage? Rust. Because it's oxidized iron. Oxidized iron. Because it's oxidized iron. Okay? Oxidized iron because it is rust. So when you have a red cell that gets oxidized, this is a Greek man who goes to a Greek restaurant and has primaquine as an appetizer, fava beans as a main course, and dapsone for dessert. And what is the most common oxidant stress to cause hemolysis with G6PD deficiency? Sulfa drugs is the most common wrong answer. What's the most common oxidant stress? That's good, that's good. Stress. What does that mean? Stress. Infection. Infection is the most common oxidant stress. So infection is the most common oxidant stress, actually the cause of the hemolysis. So when you subject these red cells to that oxidant stress, the hemoglobin, the iron, oxidizes inside the red cell. And that oxidized iron in the red cells is called what? What's that oxidized, rusty red cells? What's the rust called in those red cells? Heinz bodies. The rust is called Heinz bodies. The rust is called Heinz bodies. So the rust on those red cells are Heinz bodies. Now, when the red cells go into the spleen tries to clean up those red cells. And as the spleen tries to clean up those red cells, it bites out or takes a piece out of those red cells, and that is called bite cells. Very good. It says a bite, and it takes out, and it makes a bite cell. That's right. So, the bite cells are the removal of those oxidized iron particles. The bite cells are the removal of the oxidized iron. The oxidized iron is Heinz bodies, and when they go through the spleen, they get cleaned up and called bite cells. And that's the best you're going to do for G6PD right now. That will be the best you're going to do for G6PD deficiency right now. Okay? Now, all this other stuff is not specific. A high bilirubin? Well, any of them give you a high bilirubin. A high LDH? Any of them can give you a high LDH. A hemoglobin positive. Why is there hemoglobin in the urine? Why is there hemoglobin in the urine? Because of intravascular hemolysis, because the hemoglobin has been released into the bloodstream and it spills into the urine. Because the hemoglobin has been released into the bloodstream and spills into the urine. So therefore you have hemoglobin in the urea. Now if you have all of this bilirubin in the blood, how come you don't have any bilirubin in the urine? If you have all this bilirubin in the blood, how come you don't have this bilirubin in the urine? Huh? It's water. It's not conjugated. What does that mean? It's not conjugated. Are you conjugated? I'm not sure. Do we both need to have the same definition of that? Not water soluble. Well, where is that bilirubin? Where is all that bilirubin? Where is it? No, it's attached to the albumin. It's attached to the albumin. It is in blood, but it's attached to albumin. You see, indirect bilirubin, when it hasn't been bound to glucose and to go into the urine, is attached and stuck electrically to the albumin. So the reason that the bilirubin can't go into the urine is because it is electrically glued, like static cling, like your skirt on your stockings, stuck onto that albumin and can't get off. Because unconjugated bilirubin can't go into the urine because it is attached electrically glued to the albumin. Now, the abdominal ultrasound. Do you know why that abdominal ultrasound is there? No, it's there because if you're preparing for CCS, as well as single best answer, if this was a single best answer question, you'd never answer ultrasound. Because it's very unlikely this is ascending cholangitis. It's very unlikely this is a stone in the common bile duct. But if you're answering for CCS and you can order 10 tests and 10 treatments all at the same time, excluding obstructive jaundice, it's not a bad thing to do. If you can order 10 tests and 10 treatments all at the same time, then it's not a bad idea to get an ultrasound of the abdomen to make sure that you don't have an obstruction of the biliary system. So if this was CCS, I might order all of this because it makes a difference. If this is single best answer and it says what is the most specific test, I would answer bite cells. Yes. It depends what you mean by too many. In this, that's not too many. If you order a urine pregnancy test, that would be too many. But it's not too many for this. I don't know what you mean by too many, though. We'd have to defend it. Depends what you meant. Oh, the wrong one. Yes. If you order the wrong test, you will get negative scoring, yes. Yeah, I think so. They wouldn't give you points for the wrong test, would they? No, I don't think so. Sequence.
With respect to all of these tests, will they mark you differently if you have a different sequence of ordering?
Well, you do it, the sequence of ordering. No. If you're writing them all in at the same time, it doesn't matter what sequence you write them in. If you're ordering all of these at the same time and you hit enter, it doesn't matter what sequence you order them in. Because it's like this. Let's say you have diabetes, hyperlipidemia, and hypertension. And I write for you 3 different medications. One for diabetes, one for hyperlipidemia, and one for hypertension. And you go home with those pills. You don't have to sit at home and say, I think he wrote the blood pressure prescription first. I better take that one first. Doesn't matter what order I wrote them as long as I all wrote them at the same time.
Okay.
Doesn't matter.
Thank you for assessing my paranoia.
Okay. That's good. You assess mine later on. I'm assessing yours now. Okay? You said, thank you for assessing my paranoia. That's good. Who's going to help me with my worrying about my balding? All right? That'd be you. Huh? No, they say, would you make the history that you wouldn't order the ultrasound of the abdomen? It depends. It depends. In other words, in this case, you can't tell me for sure that there's not some degree of obstruction. You can't tell me for sure. No, I didn't say that. No, I didn't say that. I didn't say you get indirect bilirubin obstruction. I never said that. I never said that. I did not say that. I never said that. I never said that. I never had sex with that woman. I never did. I never did that.
My question is, if you have a majority indirect.
If you have a majority indirect, tends to go with hemolysis.
So why do something that's not necessary? Being in a cost-effective healthcare management system, the least cost, all this other thing. Why do that? It's not necessary. Okay,
don't do it. You've convinced me. Don't do it. Please, do me a favor. Don't do the goddamn test. Okay. Now, you see, here's the issue. The issue about CCS, this is what makes people crazy. You spend all these years learning how to answer the single best answer, and now you got to expand your mind the other way. Now you got to go back and order tests like being a regular doctor. Every admission that comes into the hospital gets a CBC and a chest x-ray and a urinalysis and a chemistry. Every single one. You say, but what do I need that CBC for? The person's here with a completely different problem. Yeah, but it's prudent care to get all of those screening tests when someone comes in. Now, if this is single best answer, would I order an ultrasound? No. If I had a person who had hyperbilirubinemia of unclear etiology, would I want to make sure that I had an anatomically normal liver? Hell yeah. That's why. CCS, you have to expand your mind the other way and get extra things. Get extra things. The PT, PTT? Well, the thing is, what's the best way to assess liver function? PT. Right? Right. You might have some liver abnormality, right? And the best way to assess liver abnormalities is actually the PT. This is an interesting group. You guys have a particular personality, don't you? It's like Marine Corps obstacle. Yeah. Go ahead. You can order them as many times as you want. You can order 10 CBCs if you want. You can order a CBC every hour for 10 hours. Do as much as you want. You can order them as frequently as you want. You have an elevated indirect bilirubin. You have anemia that's normocytic, and all of a sudden you know that you have to have hemolysis. The BITE cells tell you that it is glucose 6-phosphate dehydrogenase deficiency. Now, on the next page, you'll see that the urine for hemosiderin and hemoglobin is because the free hemoglobin is being spilled into the urine. Haptoglobin is down, but haptoglobin being down is not specific. Any cause of hemolysis can give you a low haptoglobin. Any cause of hemolysis can give you a low haptoglobin. Coombs negative because Coombs is only with autoimmune hemolysis. And the reason that Heinz bodies are here is because Heinz bodies are not visible on a routine CBC. Heinz bodies need a special supravital stain to see the rust in the red cells. And it's not on part of routine CBC testing. Autoimmune hemolysis. What would be the best initial therapy for autoimmune? I'm allergic to my red cells. What would I treat you with? Autoimmune hemolysis. Steroids. Autoimmune? Steroids. But what if I have autoimmune? Steroids. But what if I have autoimmune induced? Try steroids. Autoimmune anything. Steroids. Hereditary spherocytosis. Splenectomy. Treatment. Best initial therapy. There's only one treatment. Splenectomy. Spherocytosis. Does a spherocyte carry oxygen normally? Sure. Does a spherocyte carry CO2 normally? Sure. Spherocytosis. Spherocytosis. A spherocyte is functionally normal. A poor little spherocyte, he carries CO2, he carries oxygen, he goes to work, he pays his taxes, he pays all of his bills. The poor little spherocyte, he functions and works normally. He's just a spherocyte. He's just a short, fat, dumpy guy. Can't make it through the spleen. Poor, fat spherocyte. He's over there trying to make it through life, carrying oxygen, carrying CO2, and then he's got to go through the spleen to get cleaned up just like everybody else. And the poor spherocyte's trying to make it through the spleen. And he goes and he tries to get through. Hello, Mr. Red Pulp. Hello, Mr. White Pulp. Can I squeeze through your 2 little micron doorway? Back out, back out. And go, oh, I'm a fat boy spherocyte. I'm 5 microns across and I got to go through this 2 micron doorway in the spleen. And I can't squeeze and I can't get my fat little butt through the 2 micron doorway. And pop! And that's the problem with hereditary spherocytosis. Don't get scared. You should see the look on their face like this. It's like, ah! It's too late for a refund, honey. Okay, besides, the mortality rate in this class is very low. Spherocytosis. The spherocyte functions normally. It carries CO2, it carries oxygen. The problem is it tries to squeeze through the doorways in the spleen that can't make itself through. So as it tries to get squeezed through, it causes hemolysis. The spleen crunches down those cells because they're just too fat and chubby and too inflexible. You see, this biconcave disc of a red cell is relatively flexible. It swells and shrinks and swells and shrinks. It slides through that spleen, pardon me. Does the limbo through the spleen. Whereas the spherocyte can't do that. He's fat, short, and inflexible. And can't flop around the spleen. G6PD deficiency. Caused by too much stress in your life. Like an infomercial at 3 o'clock in the morning. Hello, friends. Suffering from too much stress in your life? The best solution for too much stress in your life is kill your husband. No. Avoid stress. Avoid stress in your life. That's where he edits out. That's where. So he's marking down that to edit me out later. All right. So the treatment is not too much stress in your life. I'll take Valium. No. I'll take drugs. No. Too much stress in your life? Don't treat yourself with drugs. Avoid stress in your life. Too blessed to be stressed. Doc, it hurts when I do that. Don't do that. Doc, it hurts when I have Primaquin as an appetizer, fava bean for lunch, and Dapsone for dessert. Doc, it hurts when I do that. I go to Mediterranean restaurants. What's the solution? Don't eat Mediterranean. Okay? Don't do that. Eat Indian. Okay? Avoid stress. So the management is avoid the stress. That's the management for too much stress in your life. Okay? All right? So we'll take a break and go on to our next case. Let's have very clear objectives about what can be obtained through a Step 3 course. Let us face the reality of the common endeavor that we're in called attempting to pass Step 3, either this small part of humanity with me or the infinite molecular part out there in video land. Hi, honey. Step 3 is an exam that for most people the score does not matter. All you have to do is pass. Now there's a few people who are undifferentiated stem cell types and have not gone into any residency yet and are doing this prior to residency and can make yourself prettier for residency programs, and then maybe the score matters. But for the 70% of people that are in residencies, the score doesn't matter. Nobody cares, just as long as you pass. But let's look at the situation here. An awful lot of people who come into Step 3 courses are people who meant to take it during their internship, Step 3. And they said, I'm a little bit busy. I'm going to put it off for just a little while. And now you're a PGY4, Child Psychiatry Fellow, Anesthesia Fellow. Is that you? I know it. And all of a sudden you're a PGY3, 4, 5, Rehab, Psychiatry, Pathology resident, and it's been a long time since I paid attention to G6PD deficiency and hemolysis, and I can't remember, and I don't want to remember. Or maybe I took the test once or twice, and I failed once or twice, and now I'm very anxious because there's something I'd like to do called pass this exam, because I'd like to get a license, because I'd like to do this thing called eat and be able to pay my rent. Because unless you pass Step 3, you can't get out of residency. You have to stay in training. So here you come into with this state of very high anxiety. Maybe I failed once or twice, maybe I never took it, and I put it off for a couple of years, and now it's been a long time since I studied the other areas, and I come into this very compressed 10-day course. I'm very, very anxious. Now, if your objective is to come in here and trying to learn all of medical school in 10 days, you can't do that. Believe me, I tried to do it the first time. I tried to skip medical school and do it in 10 days the first time through. And I couldn't do it. Okay, so you can't get all that. And you don't have to. You don't have to. You just have to get enough information and a pattern of thinking. a pattern of approach. A pattern of approach to studying, and then you study the rest later on. But if your objective is after all that level of anxiety, after the years of procrastination or putting it off or failures, coming in this high state of anxiety because I can't get out of my residency until I pass this, and now you have a very compressed 10-day course, so we want to get every single thing about medicine, you're going to have a lot more frustration and anxiety. It's going to make it harder for you. Okay? So you have to have clear objectives about what you can get, and then your anxiety level will decrease. Get me? I'm going to have to send you to Lamaze classes. Okay, ready? Cleansing breaths. Blow, honey, blow. Push. No, pushing you've been doing. Blowing is what you need to do. Relax. Okay. The other thing is that when I say something about a CCS question, and I say I can't tell you about a vague thing, like, how many tests can you do? It's not I won't tell you. It means I can't tell you. Nobody knows the exact scoring system for CCS. I can't tell you. Nobody knows exactly how many points each test is, each piece of physical. Nobody knows. We could tell you approximately. Can tell you a lot about it, but can't tell you the exact scoring system. It's not known. So remember, there's a difference between me saying I can't tell you versus I won't tell you. It's not like this. Yeah, I know the answer. Maybe I'll tell it to you, maybe I won't. Depends. Okay? Okay. So it'll decrease your anxiety level. Now let's look at another subject here called bleeding. And the first thing is, when you have bleeding, is to decide, is it platelet type bleeding or factor type bleeding? That was it. Okay. Decreases the anxiety level. Okay. Platelet type bleeding and factor type bleeding. The first thing to do when you have bleeding, before you look at the blood tests, is to decide what type of bleeding it is. Is it factor bleeding or platelet type bleeding? Is it a thrombocytopenia or platelet type bleeding? Or is it a problem with one of the clotting factors like hemophilia, etc.? So that's the first thing to do. If you start with the labs, you get confused. So don't start with the labs, start with the type of bleeding. Platelet type bleeding is more superficial. Platelet type bleeding is more superficial. Platelet type bleeding is more like gums or mucosa. Factor type bleeding is more deep. Factor type bleeding is more deep, like hemarthrosis, like into the joints. Hemarthrosis in a child, there it is, hemophilia. Hemarthrosis in a child, you're done, hemophilia. Hemarthrosis in a male child, you're done, hemophilia. Hemarthrosis in a male child. Platelet bleeding is more superficial. Gums, mucosa. What else is platelet type bleeding? Well, this is deeper bleeding, and this is more superficial bleeding. Said vaginal, but is the vagina a deep or a superficial structure? What do you say? You should relate to the vagina exactly the same way medically. Relate to the vagina the same way as what other part of the body? Treat it just like a mouth. That is correct. Relate to it like a mouth, the same way. Gums, mucosa, menorrhagia, raging menorrhea, metromenorrhagia, and all forms of endometrial bleeding, vaginal bleeding, superficial. Factor type bleeding is deep, into the joints and into the muscles, into the hematoma, muscles. Platelet type bleeding, joints, mucosa, epistaxis, skin. Superficial type bleeding. Factor bleeding is more deep. So from the very first sentence, we see, I've got a nosebleed. And we know that it's a platelet type bleeding. Right from the very first sentence. So, I've got to nosebleed. Pressure and elevation. How do you elevate your nose? I don't know. How do you elevate your nose? I guess that's it, right? I guess that's elevation. Pressure and elevation. Bleeding from both nostrils. Okay. And then they tell you that the platelet count is low here. Then they tell you that the platelet count is low. Okay. So, let's relate to this problem the same way as we would to autoimmune hemolysis. the same way as we would relate to autoimmune hemolysis, relate to ITP the same way as autoimmune hemolysis. You basically have a healthy person with isolated thrombocytopenia. A healthy person with isolated thrombocytopenia. Okay? Now, when you have a healthy person with isolated thrombocytopenia, autoimmune hemolysis, let's see. Is there an equivalent of an increased LDH for platelets? Is there an equivalent of an increased LDH for platelets? No. Now, what makes me think that this person has ITP is that we simply have isolated thrombocytopenia in an otherwise healthy person. And by that thing, isolated thrombocytopenia in an otherwise healthy person, ITP. But let's be sure. Do we have an equivalent of an increased bilirubin for platelets? Think. Try this. Try. Yeah. Each person, good. Each person has their version. No, there is no equivalent of an increased bilirubin for platelets. There is no equivalent of an increased bilirubin for platelets. Autoimmune hemolysis, increased reticulocytes. Is there an equivalent of increased reticulocytes for platelets? Megakaryocytes. Increased megakaryocytes. But that means you have to do a bone marrow. And the answer is, yeah. You have to do a bone marrow. Won't kill you. Won't kill them either. You have to do a bone marrow. First of all, the bone marrow helps you to know that there's the megakaryocytes. The second thing is the bone marrow excludes all the production problems. It excludes all the things like you see up here. Aplastic anemia and marrow infiltration and all the cause of decreased production. All the cause of decreased production you have up here, like drug-related or aplastic anemia or marrow infiltration, all of those are also excluded with the bone marrow. And you see the megakaryocytes. Now, we said that the test that was most specific for autoimmune hemolysis. What's the test that's most specific for autoimmune? Coombs. Coombs test looks at antibodies against the red blood cell. Coombs test looks at antibodies against the red blood cell. Now, in terms of platelets, is there an equivalent of a Coombs test for platelets? Yes. So Coombs test measures antibodies against the red cell. Coombs measures antibodies against the red cell. Now, there is an equivalent for platelets. That there is an equivalent test looking at antibodies against the platelets. And when you have those don't shout, quiet. When you have antibodies against platelets, what is that test called? Quiet! When you have antibodies against platelets, what's that called? Complement fixation. No. Oral fixation. Not that either. When you have anti-platelet antibodies, what's the name for that test? Shh, quiet, you. Quiet! Is this a form of medical Tourette's syndrome? The involuntary blurting out of medical knowledge? Coombs test. Church-Strauss. When you have antibodies against platelets, quiet! This is the Heisenberg uncertainty principle in medical education. Whoever I'm near becomes a little stupid. When I'm farther away from you, you become brilliant. What's the name for that antiplatelet antibody? What's that test called? Antiplatelet antibodies. Oh! Did you get that? The test for antiplatelet antibodies is called antiplatelet antibodies. Antiplatelet antibodies. Antiplatelet antibodies. Now, we said that the best initial therapy for autoimmune hemolysis is steroids. And what's the best initial therapy for ITP? Steroids. Yeah. Is it the same? Now, if autoimmune hemolysis recurs and recurs and recurs, what's the treatment for recurrent? Splenectomy for recurrent. Splenectomy. Splenectomy for both. Let's change the case a little. Go back here. We're going to make the case exactly the same. Make it exactly the same. Every single thing is going to be the same, except we're going to change the history a little bit. And we're going to say that we have this 25-year-old woman coming in, and she complains, chief complaint, I have a subdural hematoma. Everything else is the same. Chief complaint is, she says, I have a subdural hematoma and an epidural hematoma. Chief complaint, she says, I've got a nosebleed, I've got petechiae, I've got a subdural hematoma, an epidural hematoma, a subarachnoid hemorrhage, and melena. She says, I've got a subarachnoid hemorrhage, subdural hematoma, subarachnoid hemorrhage, epidural hematoma, melena, and heavy periods. All of this. Everything else is the same. Now, don't look at the next page. What's the best initial therapy? Everything else is the same. What's the best initial therapy? Steroids is. It's going to be in the answer. But it's the most common wrong answer. Don't turn that page. Okay, we're going to make her platelet count 10,000, and she's bleeding to death. The best initial therapy is what? I can't hear you. What? Transfusion of what? Platelets or blood? Blood. No, that would be wrong. Both. That would be the 27th most common wrong answer. Platelets. That would be wrong. Plasma. Definitely, plasma is definitely the 35th most common wrong answer. Platelets. It would be it. No, but I want you to notice something. Hey. I want you to notice something about these answers. There's a limited number of answers. Hysterosalpingogram is not one of the answers. Right? Brain biopsy is not one of the answers. There's a limited number of answers. You see, for ITP, steroids have their place. For ITP, platelet transfusion does have its place. For ITP, fresh frozen plasma does not have its place. But you see, you walk in there saying, what are all the wrong answers going to be? What are the wrong answers going to be? As well as the right answers. The best initial therapy is IVIG or ROGAM, anti-Ro immunoglobulins. Dr. Sakalagam there. ROGAM or IVIG, anti-Ro immunoglobulins. Go ahead, say it. No, either one. No, you got that look of bilateral Bell's palsy. That's why you look like you want to say something. You got that bilateral Bell's palsy look in the face. Okay? They both do the same thing. Okay? Quiet! You guys have the rest of your lives together. We only have a few minutes. Either intravenous immunoglobulin or ROGAM when the bleeding is life-threatening. First of all, steroids should be given, but they take a little while to work. Second of all, FFP doesn't help, not for platelet problems. Third, platelets can be given sometimes if you've tried steroids and intravenous immunoglobulins or ROGAM, and the patient is still bleeding, and they're still bleeding, and you don't know what else to do. Then you can give platelet transfusions. But if you transfuse platelets into someone right from the beginning, they're just going to get consumed and attacked and pulled out of circulation. So there's no point in using the platelet transfusion right away. IVIG or ROGAM. E would probably be splenectomy. Why not splenectomy? platelets are unstable. They got a platelet count of 10,000. They're bleeding to death. I mean, the advantage of splenectomy is, given how fragile they are, you can put your hand through the stomach and probably just reach in and pull out the spleen because they're bleeding so much. But the point is not the person to go chop into one of the most vascular organs in the body. Now that they have a platelet count of 10,000, they're bleeding to death. Not the right time. Not the right time. Okay? Does the ROGAM act on the platelets at all? Ah, the ROGAM. What does ROGAM have to do with platelets? Nothing. It has nothing to do with platelets. Does the ROGAM act on the platelets at all? No, because it has nothing to do with platelets. ROGAM. Raise your platelets. The fastest way to raise platelet count. The fastest way. Okay? Quiet. You're like the voices in my head. You're like my auditory hallucinations. Like all this whispering and all this stuff. Okay. And it's hard for me to distinguish. You ready? Once upon a time in the bone marrow. Once upon a time in the bone marrow, the big mother megakaryocyte said to her 3 little children, the 3 little platelets, 3 little platelets, 3 little platelets. You have sufficiently matured and developed enough and developed your alpha and dense granules that it is time for you to leave the comfort of your mother, the megakaryocyte, and leave the bone marrow and go out into the peripheral blood to seek your fortune. So the 3 little platelets are released into the peripheral circulation, where all of a sudden they attach to these anti-platelet antibodies, which are hanging around in the bloodstream, and the poor little platelets become coated with anti-platelet antibodies. But not to be deterred, and not that they interfere with function, the 3 little platelets continue to go through the peripheral blood. When who should they meet but the big bad macrophage? And they meet the big bad macrophage, and the big bad macrophage says, little platelet, let me come in. I'll huff, I'll puff, I'll blow down your trabecular network. And I'm going to grab you by your FC portions. I'm going to grab you by your FC portions. I'm going to carry you off. I'm going to carry you off to the spleen. I'll carry you off to the spleen that looks a little like a kidney. I'll carry you off to the spleen. I'll eat you up, gobble, 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 gobble. That's what I do. I'm a macrophage. I eat you up, eat. So the 3 little platelets go, oh, no, Mr. Big Bad Macrophage, we don't want to be grabbed off by you and carried off to the spleen. But the Big Bad Macrophage still comes by, and now the body's developed life-threatening bleeding, and the platelet count has dropped below 10 and 20,000. The person's bleeding into the brain and the gut, and 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 they have life-threatening bleeding, and the Big Bad Macrophage comes back again and goes, little platelet, come in, I'm going to grab you by your FC portion and carry you out. 3 little platelets go, oh, no, Mr. Big Bad Macrophage. In classic example of collective bargaining unit, 3 little platelets collect $5,000 for dose of intravenous immunoglobulins. And the next day when the Big Bad Macrophage comes by, they go, oh, no, Mr. Big Bad Macrophage, because we're going to inject some intravenous immunoglobulins into you, and all of your receptors are going to be stuffed up. So when the Big Bad Macrophage comes by, it goes, and that is why intravenous immunoglobulin, or ROGAM, is the fastest way to raise platelet count, because it blocks up the macrophage. It has nothing to do with the platelets themselves. And when you ever have life-threatening bleeding, intravenous immunoglobulins, or ROGAM, is the fastest way to raise the platelet count. And that's the moral of our story. Steroids, best initial therapy. Splenectomy, recurrent. ROGAM or IVIG, life-threatening bleeding. Platelet transfusions, if you've done everything else and they're still dying. If you've done everything else. FFP, never. But it's one of the wrong answers. Plasmapheresis is often a wrong answer too. Now, let's look at a modification of this. And let's take a 25-year-old woman who's got epistaxis. And she's got a PT that's normal and a PTT that is prolonged at 63 seconds. And a platelet count at 187,000. Which of the following is the most likely diagnosis? What's the best initial diagnostic test? What's the most accurate diagnostic test? What's the best initial therapy? Elevated PTT, normal PT. Elevated PTT, normal PT in a 25-year-old woman. Elevated PTT, normal PT. What's the diagnosis? Von Willebrand's or hemophilia A? Can it be hemophilia A?
No, not epistaxis.
Why not? Okay, well, let's change it. You're right. It's the wrong type of bleeding. You're correct. It's the wrong type of bleeding. So let's change her epistaxis to hemarthrosis and give her bleeding into her joint. Could this be hemophilia now? Could it be hemophilia now? Very rare? Extremely rare. Getting rarer and rarer all the time. The closer I get to you, the rarer it gets. Could it be hemophilia? Is it possible? No. Why not? She's a congenital female. She has a lifelong history of femininity, as opposed to adult onset femininity, which is so much more common these days. But the thing is, she can't be hemophilia because she has a lifelong history of being a woman. Congenital women don't have hemophilia. Women carry, men express. Women carry it, men express it. Hemophilia. Women carry it and men express it. Elevated PTT and normal PT could be hemophilia, but first of all, you correctly judged it's the wrong type of bleeding for this to be hemophilia. It's the wrong type of bleeding. But even if it was joint bleeding or hemarthrosis, joint bleeding or hematomas, it's still not in a woman. But the good news is you correctly assessed that the first thing to do is look at what the type of bleeding is first, then look at the blood tests. Because these are the blood tests that you get with hemophilia. Elevated PTT and normal PT sometimes happens with hemophilia. Because factor VIII antigen, the von Willebrand's factor, travels bound to factor VIII coagulant, the hemophilia factor. Okay? So factor VIII antigen can be down and it destabilizes the coagulant factor. Okay? So you get in von Willebrand's disease, you can get an elevated PTT, but you don't bleed from it. It's an artifact of having a low factor VIII antigen. But you have platelet-type bleeding with a normal platelet count. Platelet bleeding, normal count, von Willebrand's disease. Platelet bleeding, normal count, von Willebrand's disease. Platelet-type bleeding with a normal platelet count is von Willebrand's disease. What's the best initial diagnostic test? Mixing study is not it. That would be the best initial test for a clotting factor problem, is a mixing study. That would be looking for a deficiency of clotting factors. Not here. A bleeding time would be the best initial diagnostic test. A bleeding time. A bleeding time is my favorite medieval test. You take a blood pressure cuff, blow it up a little bit, get those veins all big and juicy, and then once the blood vessels are all filled and the blood pressure, with the blood pressure cuff, you take razor blades and you slice and you slice and you slice down, and they start bleeding. And when they start bleeding, because you're cutting them at razor blades, then what do? You time it and you watch it drip, cut and drip, and cut and drip. And that's a bleeding time. Okay, it's designed for someone with a borderline personality disorder of some kind. Okay. Later we'll find a test that we can put out cigarettes in someone's forearm too. That's a bleeding time. Now, we never said to do a bleeding time here for her. We never said do a bleeding time on her. Why not do a bleeding time on this patient? Because the platelet count is low. Because the platelet count is low. And every time the platelet count is low, you never do a bleeding time. Because when the platelet count is low, the bleeding time will always be prolonged. The bleeding time will always be abnormal when the platelet count is low. So there's no point in doing it. The bleeding time is when you have a normal platelet count and platelet type bleeding. Von Willebrand's disease. Platelet bleeding, normal count, von Willebrand's disease. Don't worry about the elevated PTT. It's there just to confuse you. It might be up, it might be normal. Best initial test, the bleeding time. Most accurate test for von Wille? Huh? Von Willebrand factor is more specific than ristocetin cofactor test. Ristocetin test is like looking for von Willebrand's factor, but von Willebrand factor level is the most specific. But you know what? They give you this case, and they don't ask you any of that. They don't ask you the diagnosis. They don't ask you the best initial diagnostic test. They don't ask you the most accurate test. They simply say, this patient, what would be the best initial therapy? Factor 8 is the most common wrong answer. Factor 8 replacement is not it. Desmopressin or DDAVP? It's the same thing? Desmopressin is the same thing as DDAVP? Yes. Well, it was when I was in medical school. I just didn't know. Is it still the same thing? It's still the same thing? Yeah. Yes, it's still the same thing. It's still the same thing. DDAVP, desmopressin, is the best initial therapy. So you give desmopressin, and it's not getting better, and she's still bleeding. What do you do now? Factor 8 replacement. Factor 8 replacement. Don't answer cryoprecipitate first. Do not answer cryoprecipitate first. Why not cryoprecipitate first anymore? It's somebody's blood. It's more than just somebody's blood. It's a lot of people's blood. It's pooled blood products. And remember, when you have contact with a blood product, you're not just having contact with that blood product. You're having contact with that blood product plus every other blood product that blood product has been in contact with. So, therefore, you don't want to use the cryoprecipitate because it is pooled blood products. DDAVP causes the release of subendothelial stores of von Willebrand's factor and factor 8. And if that doesn't work, you can give factor 8 replacements because factor 8 von Willebrand's factor travel bound to each other. Watch, look up at this case, look up. All we have to do is make this platelet count go from 10,000, put a 2 there, and make it 210,000, and it's von Willebrand's disease. That's all we have to do to change the diagnosis. Just change it from 10 to 310, 10 to 110, 210, 310, and it's von Willebrand's disease. Beware. Platelet bleeding, normal count, von Willebrand's disease. Next case. Now the cases are going to go faster and faster as time goes on. A 25-year-old man claiming to have a history of sickle cell disease comes to your emergency department. He says, I have terrible chest, back, and thigh pain. I want all of your drugs. I want all of them. I would like all the 4 basic food groups. Demerol, Percocet, Dilaudid, morphine. And you say, anybody ever give this to you before? And he goes, yes, I go to a different emergency department every month and they give me everything I want, and so should you. What would be the best initial test to tell if he had sickle cell now? LDH, bilirubin, CBC, reticulocyte count, smear. Smear. Reticulocyte count, bilirubin, LDH, and haptoglobin are two non-specific. They don't distinguish between sickle cell disease, the cause of hemolysis, and all the other causes of hemolysis. So they don't distinguish it, they don't distinguish it. So they don't distinguish between all those different causes of hemolysis. Answer. No, I didn't say that. I said, what is the best initial test? He said, if they tell you he's got sickle cell, do you have to confirm it? I never said that. I never said that. I never said that, though. I didn't ask that. I said, what's the way to initial test to tell? So the thing is, it's like this. A guy comes with an ice pick sticking out of his head. Do I need to do skull x-rays? No. But if they ask me what the best initial diagnostic test is, it's still skull x-rays. Because I've got an ice pick stuck in my head. Should I do any test? No. So it depends what's asked. Depends what's asked. The point is here is that in sickle cell disease, the bilirubin, the haptoglobin, the reticulocyte count is going to be abnormal in all forms of hemolysis. Now, when you do the smear, can the smear distinguish between sickle cell trait and sickle cell disease? Can it distinguish and tell the heterozygotes from the homozygotes? Yes. Yes, the smear can. There's something that you'll see on the smear in sickle cell disease that you don't see in the other things. Quiet! What would you see in sickle cell disease on the smear? What would you see in the smear with sickle cell disease? Sickle cells, yes. Sickle cells. Oh, very good. But it's easy to be brilliant when you're over there, isn't it now? It's easy to be brilliant when I'm over here. See, how about all this? Well, okay, get all 212 pounds, 6'4" of me right in your face like this, and it's natural to become a little dumb, isn't it? I have that effect on myself sometimes. Okay? So the way that the smear tells is that the smear tells because the smear will definitely tell you whether you're a hetero or a homo. Because you'll have sickle cells. That's the thing about sickle cell disease, is it has sickle cells. So this patient, he's febrile. He's got a little high white count. He's got a hematocrit of 25. He's got sickle cells that are present. He's got a chest x-ray shows that infiltrate, and they don't ask you the therapy because they expect you to know to give O2, fluids, and finally give him the pain meds. Here's your question. Does he need antibiotics? Does this guy get antibiotics or not? Does this guy get antibiotics? Prophylaxis? No. Does he get IV antibiotics? IV antibiotics now? Yes. Why? Why? Sorry, I mean, why? Why does he get IV antibiotics? Don't turn that page. Show a little restraint, huh? Take your time. Huh? Because he's got increased white count and a fever. He's got an increased white count and a fever. And an increased white count and a fever. An increased white count and a fever by themselves. An increased white count and a fever by themselves indicate the need for antibiotics. Even in the absence of a specific infection, increased white count and a fever by themselves means you should answer antibiotics. Why? Because of the person's splenectomized. Why IV? Because this person should be treated like a febrile neutropenic patient. In other words, if somebody had neutropenia and had a fever, you'd give them intravenous antibiotics now automatically. So you treat them like a febrile neutropenic. Basically, what you're going to do is, because they don't have a spleen, you give them antibiotics just based on a fever and a white count. So you give the guy the O2, the fluids, the pain meds, the antibiotics, and 6 hours later, meanwhile, back at the bone marrow, he's much, much worse. Those sickle cells are going into his eye, going in the back of the eye, and he's causing visual disturbance. Those sickle cells are going into his brain, going into his brain and causing him to have a stroke. The sickle cells are causing him to have malignant hypertension of the penis. What is the treatment for malignant hypertension of the penis? ICU. Going to put your penis in the ICU. And intubate it, intubate. Oh, like mouth to mouth. Transfusion. Exchange transfusion. Yeah, well, that's what editing is for. Exchange transfusion. You do an exchange transfusion. You turn them into a heterozygote. Right? Homozygotes are all hemoglobin S, mostly. Heterozygotes are what? 40% S? So basically you get rid of half of his blood and put in normal blood. It's like turning him into a heterozygote by doing an exchange transfusion, and the problems go away. Now somebody said needle decompression, and the thing is, needle decompression of the prostatic plexus of veins can be done to improve priapism, and if it doesn't get better with exchange transfusion, you would do a needle decompression of the prostatic plexus of veins. My general question is, the initial therapy, who gets antibiotics? What about for really serious stuff like stroke and blindness and retinal detachment? Exchange transfusion. And the next day, 6 hours later, his hematocrit is now, actually we'll do it the next day. Let's give him a little more time. Next day, his hematocrit is now 18. What caused that? How much does the hematocrit normally drop with the sickle cell crisis? How much does the hematocrit normally drop with a crisis? Not much. When you see a big drop in hematocrit like that, stop reading the case. Double-click on the brain icon. You can read the cases at home. They don't change if you don't read them now, okay? We're going to put this in DSM-5. Anotophobia, the involuntary fear of the loss of notes. Read the notes later on. Reading the notes that you need now is like reading the book that the movie is from while you're in the movie. I tell you, those notes will destroy your mind. They're worse than pornography. When you see a drop in hematocrit like that, what's it from?
Sequestration.
Sequestration into what? Sequestration into the spleen. What spleen? Oh, sure. It's easy to be brilliant now I'm over here, right? Now all of a sudden you're talkative. Oh, sure. There's no spleen. The spleen is the size of a golf ball. The spleen has been dead for many years now. It's been auto-infarcted. But I bet you knew that in another gyrus. Did you know they auto-infarct your spleen? Dead, the spleen. You better know it's a small spleen. It's on a different gyrus. You know they have no spleen. That's why you had to give the antibiotics. So they can't be auto-splenectomized and have no spleen and be sequestering, right? So one gyrus knows that there's no spleen. Another gyrus says it's sequestering in the spleen. It's not crossing your corpus cavernosum. Callosum. Whatever. Like, what's the difference? So, level. So the thing is, what causes that drop in hematocrit is two things. Parvovirus B19. Parvovirus B19. Parvovirus B19. When you see a drop in hematocrit, parvovirus B19. So you should be thinking of parvovirus. What else causes a drop in hematocrit suddenly like that? Decreased folate. That's right. Decrease in folic acid. That's right. Parvovirus B19 freezes the bone marrow. Zzz, and the marrow stops producing cells. It freezes the marrow. The marrow stops producing cells. And you say, but how can the hematocrit drop that much if it's only stopping production? You said production problems take a long time to have an effect. All you're doing is eliminating just the reticulocytes over the first day. What percentage of reticulocytes do you normally have with sickle cell disease? A lot. A lot. That's good. You go to medical school to learn a lot. A lot. I went to medical school with the Gambino family. How much reticulocytes? A lot of reticulocytes. Let me tell you. A lot. Typically, sickle cell disease gives 15 to 25% reticulocytes. And the sickle cell crisis, you're typically up at 20 and 25% reticulocytes. So parvovirus and folic acid deficiency, if it shuts off production and I lose just my reticulocytes, it means I lose 15 or 25% of my blood volume in a day. Because reticulocytes normally live for how long? No, red cells live for 120 days. Sickle cells don't live for 120 days. They actually have a shorter lifespan. Reticulocytes live for 1 or 2 days. So you have shorter lifespan red cells, and if I just freeze out my retics, it means in 24 hours I might lose 20% of blood volume like that because I stopped production. Because so many of my cells are early precursors. Sudden drop in hematocrit, sudden drop in hematocrit, sudden drop in hematocrit, parvovirus, B19, and the folic acid. And the next day, he manages to survive our care, and he is better. Happy, happy, joy, joy, happy, happy, joy, joy. And he's going home. What do you do for him while going home? What management do you give for him while going home? What therapy does he get while going home? Huh? Hydroxyurea is the single most important thing. Hydroxyurea is the single most important thing. Hydroxyurea. Hydroxyurea only prevents a crisis. Hydroxyurea only prevents a crisis. It doesn't treat the acute crisis. Hydroxyurea is like cromolyn for an asthmatic. It only prevents it. It doesn't treat the acute crisis. So hydroxyurea is like cromolyn. And someone always comes up on a break and goes, I didn't know we used cromolyn in sickle cell disease. It's like cromolyn in the asthmatic. It prevents the crisis. It doesn't treat the acute crisis. Huh? An asthmatic sickle cell. That's scratching your shoulder through your fly. You can reach it, but it is a stretch. Peripheral smear. Only sickle cell disease, only the homozygotes have sickle cells. Heterozygotes don't have sickle cells. Reticulocyte count normally at 15 to 20% in sicklers. Can go up even higher. High unconjugated bilirubin is any cause of hemolysis. His 18-year-old son comes to see you. Son comes to see you in the clinic. The son comes to see you in clinic and says, hey, Dad has sickle cell disease and goes to a different hospital emergency room every month for the last 9 years. But I've never had any symptoms. What test will you get for me to tell me? What's the most accurate test for me? Is what? Hemoglobin electrophoresis. The most accurate test for him is a hemoglobin electrophoresis. And he has AS. And he says, what does that mean? What does AS mean? What does that mean, Doc? And you tell him, you have a trait. You have traits. And he goes, thank you very much. But what does that mean? What's the worst thing I can expect? What can I expect? And you say, you're a carrier. And he goes, thank you very much. I'm a carrier. That's nice. And here I thought I was a wide receiver. What the hell does that mean? What's the worst thing? What's the worst thing? What should I expect? What will be the thing that will happen to me that I should expect? And you say, you are a heterozygote. And he goes, I'm going to give you one last chance, though. You're going to tell me, what should I routinely expect to happen to me? What does this mean? You get one last chance. What does it mean? And you go, what'd you say? You go, you're not a homo. At this point, he jumps over the table and beats your head into your own desk. What happens with these patients? Papillary necrosis. No, that's homozygous. They give it to their kids. That's true. Which means, but that's not the worst thing that happens to them. They give it to their kids, that's true. That's why dating is hard enough as it is. But you got to go, oh, gee, I think you're cute. Yeah, I think you're cute too. Yeah. Well, let's get together sometime. Okay, no problem. I just need one thing from you. What? My number? No. Need 2 red top tubes of blood. What's for? Well, one's for the hemoglobin electrophoresis because I don't like to build up too many recessives, you know. Well, what's the other red top tube for? Oh, you know. So you can pass it on, but that's not the worst thing. Hematuria and isostenuria. The kidney problem. What'd you say? Not so much UTI, but the kidney concentrating problem. The hematuria and the isostenuria. That's the kidney problem is routinely found in the heterozygote. The kidney problem. Renal. What do you see in a CBC with the heterozygote? What do you see in a CBC? With the heterozygote? Normal. They're hematologically normal. They're hematologically normal. The heterozygote is hematologically normal. Now, this is why we did sickle cell disease separate from the other case. Sickle cell disease is a great question for step 3. Pardon me. It's a great question for step 3. First of all, it's a very common disease. 8% of African Americans are heterozygous. That's huge. It's like 1% of the total population. It's a huge number of people. It's a great question. You have the initial therapy question and to figure out who to give the antibiotics to. The other thing is something happens to the patients that they don't like if you withhold the antibiotics. What happens to the patients if you withhold the antibiotics here that they don't like? They die. They die. And they say, Doc, I don't like that when I die of sepsis when you withhold the antibiotics. That's bad. The initial therapy, the initial who to give antibiotics to. What to do for life-threatening sickle cell disease. How to recognize what caused the drop in crits, parvovirus and folic acid deficiency. The preventative treatment with hydroxyurea. The heterozygous question. Hematuria, isostenuria. The most accurate diagnostic test question. Hemoglobin electrophoresis. Sickle cell is a great disease because it's common and it's lots of nice, interesting questions for you. It has many nice, interesting questions for you. Next case. And you got an old lady who comes in and she's got a little bleeding. Now, bleeding. Coffee ground emesis. How much blood do you have to lose to have coffee ground emesis? Almost nothing. Coffee ground emesis is like guaiac positivity. You don't have to lose very much blood at all to have coffee ground emesis. 1 or 2 tablespoons of blood in the stomach can give you coffee ground emesis. Now, the big issue here is that you have a PT that's elevated at 16 seconds and a PTT that's prolonged at 45 seconds. And when it's at your level, you think that there's about 100,000 things that can cause an elevation of a PT and a PTT. And the answer is, there is not. There is not that many things that cause an elevation of both the PT and the PTT. Here's factor 7 activating factor 10. Factor 12, activating 11, activating 9, 8 off to the side here. There's not that much that does that. Prothrombin to fibrin. There's not that much that does that. There's not that much that's going to elevate both the PT and the PTT. At your level, it comes down to basically 3 things. Liver disease, vitamin K deficiency, and DIC that elevate all the 3 of those, okay? That elevate all of those, the PT and the PTT. There's not that many things that do that. Now, right away, from what the information you have right in front of you, what do you have right in front of you that tells you this can't be DIC? There's no schistocytes. No, because they didn't give you a smear yet, did they? Did you see a smear? The platelets are normal. Well, right away, what tells you right in front here is that here, the platelets. Here, the platelets are low. The platelets are low. And it comes down to that although there are specific tests that you can do, it's easier to just give vitamin K and see whether it either gets better or it's the same. To tell the difference between vitamin K deficiency and liver disease. Now, this person has normal platelets. They've got an elevation of both the PT and the PTT and normal platelets. They're telling you that the fibrinogen is normal. That's a way of telling you it's not DIC. The AST and the ALT and all the liver function tests are normal is trying to tell you it's not liver disease. However, that's only suggestive because the day you die of your cirrhosis, you have normal transaminases. The day you die of your cirrhosis, your transaminases are normal because the liver has no more enzymes left in it. So it's only suggestive. So you give vitamin K and it's either better or it's not. Now, why would this person have vitamin K deficiency? Because of the antibiotics. See, when you give her those antibiotics, you're wiping out the bowel flora in her gut. And when you wipe out the flora that's in her bowels, she gets vitamin K deficiency by wiping out the bowel flora in her guts, because those bacteria make vitamin K. Elevated PT and PTT, 3 basic things for you. It is extremely unlikely that they're going to give you a factor 10 deficiency or prothrombin deficiency. For you, elevated PT, PTT are 3 things. Liver disease, vitamin K, and DIC. DIC gives low platelets. This has normal platelets. They're giving you all the transaminases and everything else in the liver is normal. It's easier just to give vitamin K and see if it gets better. Let's take a break and we'll come back to the next case.